shit.
I'm taking
one-liners, man. None of my one-liners got saved.
I'm taking screenshots of it. So
okay, so if we add hypertonic fluids to a blood vessel, what's that mean? What are we adding? So if I add 3% normal saline to someone's blood vessel, what am I doing?
So the fluid that is outside the blood vessel is going to be pulled into. It's going to enter the blood vessel because of the higher concentration of solutes in the hypertonic fluid.
So when I drop fluid out of the extracellular space in cerebral edema, what have I done to my edema if I'm drawing that fluid back into the blood vessel? I'm relieving it, right? I'm chemically relieving that. Okay, perfect. What's another way that I can relieve cerebral edema, swelling in the head? There's this. Well, Addison always goes for the knife. Addison is a knife person. She loves going for the knife. Okay, so we can.
Hey, Addison. I was gonna say that too.
Piece of the bone. Surgical decompression. Addison loves. Say, Addison, you love the knife. Just say that. Come on, Tanner, say it. You got to say it with me. Okay, on three, we're going to say Addison loves the knife, and you got to say it with me. 1, 2, 3. Addison loves the knife. Okay, Addison's going to be working as an OR nurse because she wants to cut people all the time. Addison, that's your calling. You know what your calling in nursing is now. Addison's going to be working in the
their stomach or their abdomen.
Yeah, we basically we can put it back in their body somewhere else and retain it there for later reinsertion, or we can freeze it. Okay, and I think you work in an OR, right? You work as a surgical tech.
Yes,
we do that all the time.
So, yeah, if it's more short term, that they're going to need that bone flap off. I believe they freeze it. If it's longer term, they're going to put it somewhere where it has a blood supply.
You can come over here if you want. Come over here.
I'm good. I don't.
Addison doesn't want to be on camera.
How long do they put it in the freezer for?
I'm not sure.
And like, don't you think infection would get in there if they're just having to wear a helmet?
Okay, so that's a good question, and I think I know something about that. You know what they do with those? They drain them all the time. They're constantly irrigating those, right? They're irrigating those wounds a lot to keep infection out of there. Yeah, and they're actually it's covered. They cover it. Yeah. Have you seen the little skull cap things they put on people with those? It looks like a little mesh, weird, shitty thing, and they put the helmet over it. And then the helmet has like the pads around that spot, so it holds the pads hold it on the stable bone and holds it off of it. It's like it's really a kick-ass looking thing. I mean, it's crazy. But yeah, that's what I've seen. I've only seen this one time in like real life, and it scared the shit out of me. Okay, I'm gonna be honest. It scared the living bitch because their brain was visible. Like you couldn't see it, but you could see the piece of bone removed, and kind of the helmet had a little opening. You could see in there, so the docs and nurses could inspect it without taking the helmet off. And I just happened to see it, and I was like, oh my freaking A! Yeah, it was pretty crazy looking. I've only ever seen it one time, and it scared the bejesus out of me. Okay, so that's surgical decompression. That's the fun one. So Addison, I like the knife. Addison likes the knife. Okay, I'm going to use a really interesting one. Mr. Newton in like 1582 in England and discovered this amazing thing called gravity. So gravity is a thing that we can use for almost all these cerebral injuries. Tilt them 30 degrees. Put some gravity on them, and just gravity will start to pull fluid out of their brain. Okay, because we can't, like on a wrist that's swollen, we can put a bandage over and compress it. We can't do that to the brain, so we use gravity to help us to do it. So gravity is one of the things that we can do.
Or positioning.
Yeah, we call it positioning, or I just say gravity because it's easier for me to remember that. But yeah, positioning. Okay, what's another way that we can? So if we can draw fluids off because of hypertonic. There's another way that we can draw fluids out of the body. Think downstream. What can we do to them?
Diuretics.
Yeah, diuretics. They can pee it out. So the on-spot place is hypertonic. When we go hypertonic, that fluid's got to ultimately go somewhere. Where does hypertonic fluid ultimately end up?
In the bladder.
Kidneys piss it off. So in addition to hypertonics, we can do diuretics. And diuretics cause urine production, and that just gets excess fluid in the body as a holistic approach out of the body, and that alone is going to cause fluid from the brain to be pulled off as well. So it's like a double whammy. Hypertonic and diuretics both do that, and they draw fluid out. Okay, the last one, it's hormones. They're called corticosteroids.
Steroids. Yeah.
So corticosteroids inhibit inflammation. They're the anti-inflammation steroids. So you give them corticosteroids, that drives the inflammation response down, and that's going to decrease cerebral edema. So gravity, hypertonics, diuretics, corticosteroids, and surgical intervention. Addison loves to cut people. Addison with a knife. Okay, are we good? So now that we've talked about cerebral edema and its treatment, we want to talk about ICP. So ICP is what?
Increased intracranial pressure.
Yep, there are short-term and long-term symptoms of this. Okay, what do you think? What is one of all the symptoms that's in every neural injury we can talk about? Every injury has this one.
LOC.
LOC changes, right? They're going to be pissed off and irritated, and they're not going to know where the hell they are.
Mm-hmm.
If they got cerebral edema going on, and they got intracranial pressure going up, they are definitely short-term. Immediately, you're going to notice a decrease in LOCs. As they get ICP and LOC changes, that means there's fluid in their brain. What are some of the structures that don't respond well to pressure in the brain?
The ventricles in the brain.
Yeah, the ventricles don't like it, but we're talking more specifically, there's two vision problems. Their pupils will become irreactive to light. They'll be uneven. Light will hit them and they'll respond differently, which they shouldn't normally do. And then the other thing is they'll just start getting vision problems because there's pressure on the ocular and optic nerves, and so they can't see as well. They start to get blindness because they just can't see because of pressure on those nerves. Okay, the next one, decreased LOCs and headache. I just put those together. Anybody getting decreased LOCs is probably going to have a headache. And then vomiting. Yeah. Why are they vomiting? Why would they be vomiting?
Oh, I saw it in the notes.
Well, it has to do with the nerve that runs their stomach, their guts. It's a parasympathetic nerve. It's cranial nerve.
Vagus nerve.
Yeah, the vagus nerve, so it gets compressed. As it gets compressed, it causes them to vomit. They want to throw up. And that's not a good sign of disease. If people are throwing up, that's bad. If any time you see somebody throwing up that you could think has a head injury, that's no good, and that's definitely see a doctor thing. Okay? And then notorigidity. Do you know what notorigidity is? It's a stiff neck. They can't flex their neck. Okay, and there's two places you'll see that. In cerebral edema is one place, and in meningitis you'll see it as well. Those are the two major areas that we see nocturnal.
Okay. Bye, Mariana.
Nostril rigidity, okay? That's the neck stiffening. Okay, so early signs. Okay, those are pretty straightforward, okay? LOC headache, vomiting, vision problems. That's pretty much it. That's all of them. And then their neck is sore. They can't move their neck.
Right.
Okay, that's pretty easy. Now, the late signs are a little bit weirder because they're okay, so your acute signs are these ones, right? Your late signs are more chronic signs, okay? So impaired reflexes, corneal gag and swallowing. They get where they can't swallow, they can't talk, okay? And their eyes, they start getting corneal problems with their iris and cornea not working. So in addition to being like they're having vision problems, these are like long-term. They get permanent changes in there and they can't see. Okay, papilla edema. Okay, so papilla, have you heard the term papilla before? That's an anatomy term.
Yeah, let's see. Yeah, there's papilla in your brain.
Yeah, your eyes. You have a papilla in your eyes. So if you haven't noticed in cerebral edema, what's the main thing that's getting jacked up? How many times we talk about their eyes being messed up?
Your eyes, yeah. Like
4 or 5 times compared to LOC, headache, throwing up, their neck hurts. Eyes. So eyes. Okay, their eyes don't work. And then the last one is abdominal posturing. What are the two kinds of abdominal posturing we're worried about?
The abdominal posturing?
Yeah, there's two kinds.
Oh yeah, the decortica and decerebrate.
Okay, so where's decortica injury at? Where's the decortica injury at?
That was.
Is it higher or lower, Addison?
Brainstem.
It's higher. It's higher in the cerebrum and the brainstem. Where's the cerebrum at? If the
that
top
was in the midbrain.
Taken up, then it has to be the lower one, which is called the brainstem. It has to be the brainstem.
Right. Okay.
Okay, we good?
Yep. Hey, I gotta go now.
Okay, have fun.
Thanks, guys.
You're the best.
No, man.
You're the best around. Nothing can ever bring you down.
What time are you gonna be there tomorrow?
I'll be there at 11:30.
11:30. Okay. I'm gonna be there.
I'm gonna be out in the classroom and then when they clear out, I'm just gonna go in.
You're gonna what?
I'm gonna be at the classroom and then I'm just gonna go in at noon when the other class finishes. It's just too much bullshit to move again.
Okay.
I'm just gonna go to the classroom.
Okay.
Yeah, it'll be fine.
Sweet. I'm gonna be there probably around 8:30, 9 o'clock.
Okay, cool.
Okay.
Have fun at work.
See you guys. See you, Addison. What'd you say?
I'll just kick him out. I can eject anybody if I want to.
Can you really?
I can eject people. I can turn their mic off. They're talking funny. I can shut them up. I can literally just mute them. I can turn their camera off. So if they were stripping and getting naked, I can mute their camera, turn their camera off so they can't see them. I can do everything I want. I can kick them out. I can just eject them. I can block them. I can eject them and then block them. If they try to, because they have the link still,
Yeah.
I can block their link access so they can't get back in. So they can go to the TV show part and they can watch on the TV show and they can comment here, but only I can see their comments here. You guys couldn't see their comments, could you?
No, you can.
Okay, well I can block their comments too. There's a way to block their comments. Okay, so let's get into the case. Let's do this. So long-term signs of ICP were impaired reflexes, corneal gag, and swallowing.
Okay.
So those are the three. And again, eyes is a big one, and swallowing and gag is a big ones, right? Okay. So those are long term. Okay, then we have Cushing's triad.
So what are short term?
So think about it. What would acute? So I've got intracranial pressure.
Yeah.
What would be one of the first things that you'd see happen to somebody? Anytime there's any one of these, what do you think they're going to have?
LOC.
LOC changes and headache.
Yeah.
You take a hit to the head, you're going to have a headache.
Nausea.
Yeah, nausea and vomiting.
Yeah.
Because why would you have nausea and vomiting?
Honestly, I don't know.
Cervical nerve, cranial nerve number 10.
Okay.
The vagus nerve controls the GI system, and now you're pinching it off and putting it under pressure, which causes a vomiting response on the system. Okay, so that's that one. Okay, vision. Pearl, they're going to lose pearl, and they're going to lose vision. They're going to start having a hard time seeing, and then headache, and then vomiting, and then nostril rigidity. Their neck is going to be stiff. They won't be able to twist and bend their neck. Their neck will be like locked in place.
It says see meningitis signs and symptoms. Yeah,
meningitis talks a lot more about it, but they talk about it here too. And let's be honest, what's meningitis? What is meningitis? It's swelling of the brain.
Yeah.
So that's not a big shocker. It's a swelling of the brain. Okay. Okay. So Cushing's triad: hypertension, bradycardia, hypoventilation. That's exactly opposite of shock.
Mm-hmm.
Shock is hypotension, it's tachycardia, and hyperventilation. Mm-hmm. So that's the only reason I remember it. That's the only way I can remember it.
Yeah.
And we can get into like all the vasodilation or whatever, or just know what it is. Okay, head injury. Do we need to go over head injuries? You want to go over that one?
No.
Let's hit Alzheimer's. Okay, so let's do the hematomas really quick.
Yeah, let's do that.
Okay. Well, okay. So let's see. Let's see here. Okay, so there are they talk about 7 different head injuries: concussion, loss of consciousness, no CT, contusion, bruising with CT verification, laceration, tear tissues with CT verification, cerebral edema with CT verification. Short term, you won't see it, but long term, you'll see CT scan. The brain will start to shift. Okay. Then there's herniation, which is, again, as fluid builds up, it starts to push the structures to one side. The worse that is, the longer it goes on, the worse it'll get, as well as it'll start to herniate through the foramen magnum at the bottom, which would be really not good if that's happening, okay? Acceleration, deceleration injuries are counter-coup and counter-coup, which means they hit something and they hit back. Both the front and the back will be injured or bruised, and that's what it means. So you basically get 2 brain injuries for the price of 1. And then cardiovascular infarction, which, again, right? Cardiovascular infarction, which means they're getting a blockage, right? Well, that's a CVA.
That's a CVA.
That's a CVA.
What is that?
So that's TIA, which is transient ischemic attack. So it's ischemia.
Yeah.
So that happens 2 ways. There's hemorrhagic and blockage.
Well, what's the CVA?
Cerebral vascular attack.
Okay.
And this is cerebrovascular infarction. So one other way of saying this is CVI, because infarction is what's going on, right? Infarction means cell death, right? Because we can get an MI, a myocardial infarction, full heart attack, blood's being lost or kept from those structures, and they die. Yeah. As those cells start to die, what do they start doing? They go necrosis, and they let all their internal components out, and they poison everything around them. Yeah. So that's what's going on there. So stroke.
Which would be the attack.
Yeah, right? That's the attack part. Yeah. So stroke, there's hemi, which is hemorrhagic, right? Bleeding, and this one is blockage. Yeah. Right. This one is I'm siphoning water off I'm irrigating my land and pulling water off the river. Yeah. This one here, I dam the river. Okay. And that's the only way I can remember it.
Okay. Let's go over hematomas.
Okay, yeah. I'm just saying, let's hit the ones we haven't really talked about. Yeah. And those ones we hadn't, for some reason, we just blew those off. We just had blown those last 3 off. Yeah. I want to make sure we hit those. Okay. And see how these overlap? There's all this overlap. Yeah. They're overlapped. So like, meningitis. What do you think one of the signs and symptoms of meningitis is going to be? Headache and nausea. You know, like, what's one of the signs? What's the sign and symptom of a spinal injury? Headache and nausea. Because, Alzheimer's, headache and nausea. I mean, like, you kind of can get away with some of this because there's overlap, okay? Yeah. So hematoma. So epidural hematoma. What's epidural?
So that would be in the dura. Let me think. The blood clot that forms between the skull and the top lining of the brain. So the dura, yeah.
So epidural is here. Okay. What's the next one?
Subdural.
Okay, what does it say about that one?
Between the dura and the brain tissue.
So that's basically saying anywhere in here. Because you got dura, arachnoid, and pia. And what did it say? Anywhere between what?
Between the dura and the brain tissue.
That could be any layer. So subdural is here. Sub is anywhere in here.
Okay.
Okay.
And then intracerebral is a blood clot deep in the middle of the brain that is hard to remove. Pressure from this clot may cause damage to the brain. Surgery may be needed to relieve the pressure.
So does that look like cerebrum? Like,
oh wow, yeah.
Okay. Skull, dura, arachnoid, pia, brain matter.
So it goes back to anatomy. It goes the skull, and then it goes
dura mater.
Well, isn't there like the space? Obviously, isn't it?
Yeah.
Like
well, no, because the space here, dura mater actually sits right on it. It sits really close to it. You have to peel it away. When you pull so if you ever cut into the brain and pull a piece of the bone away, you hear it go. It's because you're pulling the dura mater away from the skull.
Okay.
I'm drawing it like this so we have some space to see it. That makes sense?
Yeah.
We can put it where the epidural damage is.
So what are the spaces though? Because it goes.
So dura, that's epi. This is the dura between the arachnoid is like this is technically subdural. This is subarachnoid, and then pia doesn't have a space. It's actually on the brain. Remember, it sits in these. This pia mater sits like this.
Yeah.
It actually sits in those spots, and that's where you're like. That's where like your like central fissure, it's pia and dura mater like that sink down in there and form all that stuff, and then subarachnoid as well. But these things are basically for this class You have to know this less intense in this class because you have to know epi, subdural, and then intercranial. See what I'm saying? And they combine 3 of them to be subdural.
So is it? I guess I'm kind of confused because is the epidural, is that after the dura mater?
No, epidural is so it's like this. Here's the skull, right?
So does dura mater line the skull, and then also is that the top layer of the brain?
Yeah,
I guess is my question.
So basically the dura mater sits actually co-joined to the skull.
Okay.
Right here. So to get a bleed in there, this actually peels off and creates a space for that. The dura mater peels away from the skull and a blood clot or fluid forms in there.
Okay, so then the dura mater is the top part.
That's the top layer, yes.
Okay.
And then your arachnoid space is here, and like that's why I drew that little spiderweb looking thing below it.
Yeah.
That tells you that's what it is.
That could be in the pia mater.
No, pia mater separate, and then pia mater sits below it. Pia mater, and then pia mater sits right on top.
So the subdural hematoma is between the dura and the pia.
Yeah, it's in here.
Okay.
Yeah. Because see here, this is peeled away. That's peeled away.
Yeah.
So in this example, it's not peeled away. It's right here.
Yeah.
It's not. It's in this space, and this part's pushed against the brain, still not peeled away.
Yeah.
And then inner cerebral
is just in the brain.
It's in the brain matter itself. And this is like what people who smoke get. Okay. People who smoke and when you cut their brain, they'll cut them. There's a really cool ad on the cut through. There's a big old space in there, just blood clot like falls out. That's nasty. Don't ask me to say that again. Okay. Okay, Alzheimer's. What's Alzheimer's?
It's like the natural process of
degenerative is the word we're looking for. Degenerative. It's just degenerative, right? It means so. Who gets it?
Older people.
Yeah, older people. And then, what are the stages?
So it's like your short-term memory, then your long, or kind of your functions. I feel like.
Yeah. So it's short-term confusional.
Okay.
And then incontinence and long-term. So basically, the first 2 stages are only like memory and like brain function. Mm-hmm. The third stage, they're starting to lose the ability to tie their shoes because of physical. Okay. So short-term memory loss is first, and then second is confusional, disorientation, lack of insight, impaired hygiene, and language use. And then sundowner syndrome. They get worse at night. They get worse at night. And the third one is incontinence. What's incontinence mean? They just defecate themselves when they want. They're like a kid. They just start defecating in a diaper because they just go whenever they just go. They forget they can go to the toilet and they just go. Mm-hmm. And then long-term memory loss is the inability to recognize people. But incontinence is also meaning they may forget how to tie their shoes, mm-hmm. right? Where they may maintain that for a long time in the first and second. And then in the third stage, when they start expressing the weird physical changes. Okay, the pathophysiology is those proteins that wrap around the nerves. They wrap around the nerves and start to pull them apart. That's what those proteins are doing. They physically denature the axons and pull the axons apart.
What are those called?
They call them tangles up here, but they're called neural fibril tangles, causing areas to degenerate tissues called senile plaques. I just look at them and say those proteins like go. Have you ever seen like weeds in your garden?
Yeah.
You'll have a piece of corn growing up, right? Mm-hmm. And there'll be a noxious weed that starts to wrap itself around the corn. And what does it do? It stunts the growth and eventually kills the corn because the corn can't grow with that thing holding onto it. The same is true with these kind of plaques. That as those plaques start to form, they wrap around the axons and they physically start to pull them apart. Okay. And that's where the degeneration comes from because it starts to make the brain smaller because it starts to compress all those axons and pull them together.
Okay.
Which is kind of nasty thinking about it. Okay. And then so that's the patho. So what's the incidences? There's familiar and non-hereditary.
So familiar or early onset.
Yeah.
30% of cases occur before 50 years.
Yeah, they're young.
Okay.
And then non-hereditary is older people, and that's the majority of the cases.
Okay.
Okay, signs and symptoms. Oh, they get headaches. Sorry, I'm just teasing. No, but we already talked about the signs. In the first stage, their short-term memory starts to go. The secondary, they start to get a little bit delusional. They start to have issues with like orientation, where they're at, stuff.
Yep.
Okay. They start to act crazy. Like they'll start to act nuts and do things that are not normal. And then the third stage, they start to lose the physical abilities to maintain their own lives, and they can't remember people. Like they don't remember who their family. Like you'll care for them every day, and you walk in there every day, and they don't know who the hell you are.
Yeah.
Which that's kind of sad. Like they just hate you. Who are you? Okay, cognitive. Without looking at all the details, what's cognitive?
Just thinking.
Yeah, they can't read, they can't do math, they can't balance their checkbook. Okay, behavioral. They're angry.
Aggressive.
Yeah, they're angry and pissed off all the time. Mood.
Same.
Yeah, they just fluctuate in mood, right? They could be happy 1 second and they crash, and now they're pissed off.
Yeah.
Psychological hallucinations, depression. Yeah. Okay. And then commonness, restlessness, inability to, like loss of appetite, and then inability to coordinate muscles and jumble their speech. Okay. And we just supportive care. There's no real. We can give them medications, but it's all palliative at this point. They're just going to degenerate. Yeah. We're just trying to help them maintain it. Do you want to go to the little brain map thing here? Poor judgment versus just typical age-related stuff. Hell, I forget where my keys are. You know, I mean, like shit, I forget stuff. Like I'm on this list, and I don't have Alzheimer's. I'm not even that old. So, okay, CVA. You want to go through CVA? So ischemic, embolic, hemorrhagic.
I feel like I'm kind of good on those.
Okay, let's go through aphasia though, really quick. Down here. So if you go to the next page, talks about aphasia. What is aphasia?
That's the
A means absence of speech. Okay. So aphasia or absence of speech can be called by CVA. So expressive aphasia, the patient understands what is being said to them but cannot converse back. Okay. And receptive aphasia means they can speak but they don't hear you. Okay. So expressive is they can't express themselves. And receptive is they don't, like you'll be talking to them and you'll see that the lights are on, but no one's home, and they'll just start talking about their kids. Yeah. And that's not what you were talking about. Okay. And then hemiplegia is that's the one side of the body dying, like in a stroke. That's the one side being paralysis, whether it be the eye, their mouth, and their face, or their arm not working. That's hemiplegia. Okay. And then the 3-hour window to treat thrombolytic and embolytic strokes. And then hemorrhagic, we don't treat with that. Okay, and then fast, what's fast?
Face drooping, arm, if you raise them. C is for...
It's not C.
Or S, speech. T is time.
There we go. Okay, transischemic attack.
T, that's the mini stroke.
Yep, mini stroke, and we kind of beat that to death. Okay, just really quickly, pathology of spinal cord injuries. This is all pretty easily. This is pretty easy. So anything in the cervical region, what's that going to be? Anything broken up here?
Paraplegia.
Yep. Anything? No, it's quad. All 4 limbs will be damaged. Quad means 4. All 4 limbs.
So para that's means, up here?
Yeah. Cervical is quad. Anything below that is going to be it's lumbar. Is going to be para, which means 2. Okay. Para means 2, or bi. It means bi.
So if it's up here, quad.
Quad.
If it's lumbar, it'd be paraplegic.
Yep. Okay. And then anybody who's got C1 to C3 needs a
chest.
They need Darth Vader. We need to ventilate them. We will have to breathe for them because they won't be, because that's their phrenic nerve's been damaged and they won't be able to breathe. Okay. Okay. Spinal shock is
it's like a shaking.
A good shake of their spinal cord, right? Okay. And it causes sensory overload. They lose sensory overload. It causes their nerves to not work. They're not damaged. They're just overloaded. So like if I get a flash bulb and flash it in your eyes, what happens? You've overloaded your eye neurons, right? Yeah. And you have a white spot in the middle of your vision. Oh, I hate that. Yeah, it pisses you off, right? Or a loud noise, right? You hear a loud noise, you get ringing in your ears. Yeah. That's a neural response to you overloaded me. Okay. The spinal shock, the same thing. You just overloaded your spine. And so it causes those. It lasts from 1 to 3 weeks, but as long as 3 months. And they can have hyperreflexia, or twitchy stuff for a year. Okay, compressed and transected. What's compressed?
Compressed. I don't know.
Yeah, squozen. Yeah. Transected is cut. Yep. Incomplete and complete spinal injuries. Incomplete is. This has got my favorite phrase in it, so you better remember this one.
Anal.
Yep. Involuntary anal reflex or anal link is incomplete. What does incomplete mean?
Incomplete?
Yeah, if I have an incomplete spinal injury, what does that mean?
It's not complete, like it's
there's a chance for recovery, right?
Yeah.
That there's still neural impulses going on
Yeah.
between the top and the bottom. There's a chance to recover.
Mhm.
If you get a complete spinal injury, it's done. Wherever that severed part is or broken or compressed part is, it's done. You're not going to recover from that. Complete. Okay, so and again, it just says here motor and sensory. Motor and sensory are the two pieces to it. So if in incomplete, you may have complete motor function and lost sensory.
Mhm.
You could have all your sensory inputs, but not your motor responses.
Okay.
But in complete, they're both gone. And then it talks about reflexes and autonomic function. But let's be honest, if you covered motor and sensory, you covered those.
Okay.
Okay, autonomic dysreflexia. You're going to explain this to me online. I'm going to erase this, and you're going to explain autonomic dysreflexia to me. Because this is pretty complicated, and I want you, but this is cool. Okay, come on up here. Get yourself a cool guy pen. Draw yourself a picture, too, on this one. You're going to need to draw a picture on this one.
Oh, gosh.
You're going to be able to do it. You're going to be fine.
I feel like all I remember is it's when the body's basically like split and half of it.
That's a good place to start.
The brain is telling you that it's okay, right? But then
no, the brain knows something's wrong. It just can't communicate with that body part to tell it to relieve it. Okay, so come on.
The brain isn't getting the signal.
The signal's not getting to the organ or whatever. Okay, come on up here. So draw yourself a cool guy in a wheelchair. I'm serious. Draw yourself a guy with a wheelchair.
Oh,
that's who's going to get this. It's not going to be anyone crutches.
Is this recording?
Yeah, it's on. It's recording for posterity. What do you think? You got to be on there, damn it. Come on, get up there. I'm going to just keep pushing it on you.
No.
This is Addison. She's going to explain. That's fine. That looks great. Put a little wheel on it. There, wheelchair in it. Put a person in it. A stick figure man. Okay, that's good. That looks great. Okay, there's our stick figure man. So in autonomic dysreflexia, what's going on?
Okay.
Where's the brake have to be?
T6.
T6 or
above.
Okay, so put T6 and put an arrow going on. There you go. So what's going on? So what's below T6? What's all below it? Guts and legs, right?
Yeah.
Okay, well, I need to go pee right now. And I have a spinal cord break at T6.
Okay.
So can my brain know that I need to pee right now?
No.
So how does it know? How does it know that I need to pee? What happens to make it know that I need to pee?
Because you get cold and like fidgety.
Well, it starts to fill up, right?
Yeah.
So your bladder starts to fill up. So the normal response is your normal response would be for your sensory organs inside your bladder to tell your brain I'm full, pee. Those are severed now. So what happens is that organ gets under stress.
Yeah.
And what happens then? It starts to secrete hormones and other electrolytes to say, I'm under stress.
Yeah.
And that's getting to the brain. How does that get to the brain? Through the blood and lymphatic systems. Other systems that aren't severed keep getting up there.
So it's not really like the signal from you need to go pee. It's the stress.
It's the stress from I need to pee. It's overfilling, and it's like I'm starting to fill up too much. I need to pee. I'm not peeing. What's going on? So a stress hormone, a stress response is solicited.
Okay.
And that's getting to the brain through another system besides the neurology, right?
Okay.
Okay. And then also that organ is sending neural signals up because it doesn't know that it's been severed. It doesn't know. Okay. So both systems are working. It's sending neural signals that are hitting the brake and stopping there. And then it's sending out the stress response. Well, when a stress response happens, what happens to the blood vessels? They want to get the pressure up because it's a stress response.
Yeah.
So they start to dilate. And the pressure goes up in those areas. Well, the brain doesn't, it's like, what the hell's going on, right? So it drops blood pressure.
Yeah.
And dilates above and constricts below.
Yeah.
So they constrict below the injury site and they dilate above, which drops blood pressure above that. And then the blood pressure and the heart rates are going down.
But then on the bottom side, it would be increased. Okay. Because it'd be right?
Yeah, so here it is. I'll read it. Yes, let me read it. It says the brain attempts to maneuvers to halt the progression of hypertensive crisis. Okay, so again, the strong sensory input travels up the spinal cord and invokes a massive reflex sympathetic surge. This thoracocolumnar sympathetic nerves causing widespread vasoconstriction, most significantly in the subdiaphragmatic and splenic vasculature below the level of the injury. So peripheral arterial hypertension occurs. The brain directs the hypertensive crisis through crisis. First, the brain attempts to shut down the sympathetic surge by sending descending inhibitory impulses that don't make it, because those are going to the spinal cord. These impulses are unable to travel to most sympathetic overflow levels because the spinal cord at injury T6 or above inhibits impulses are blocked. Inhibitory response impulses are blocked in the injured spinal cord. Okay. The second maneuver, the brain attempts to bring down peripheral blood pressures by slowing heart rate through an intact vagus parasympathetic nerve. However, this compensatory bradycardia is inadequate and hypertension continues. Once the inciting stimulus is removed, the reflex hypertension is resolved. Okay. In summary, if the sympathetic nerves prevail below the level of neurologic injury and parasympathetic nerves prevail above the level of the injury, the sympathetic response causes vasoconstriction below, driving blood pressure up, and parasympathetic nerves cause vasodilation above, which is bradycardic and causes blood pressure to drop above. Pounding headache, visual changes again, there we go, axillary, pallor, and goosebumps below the level of injury. Those are all stress responses, okay? And then ultimately, it's going to drive them into cardiac arrest eventually. That's what's going to ultimately happen. So hypertension due to vasoconstriction, pounding headaches, slow heart rate bradycardia come to compensate for hypertension, flush face and or red blotches in the skin above the level of spinal injury, sweating above the level of the spinal cord injury, okay? Sweating, that's a stress response. Skin, that's a shock response below. So you're having two countering things in the same person that should normally be one or the other, and they're both happening at the same time. That would be cool to see. It would not be cool to see, but it would be cool to see it. Okay, and the goosebumps below the level of the injury. Okay. And then what it says there, autonomic dysreflexia is a commonly tested NCLEX topic. So it's worth remembering, wink, wink, which means we're probably going to see it on our test.
Yeah.
I love it when they tell you that because it means you're going to, yeah. Okay, that's autonomic dysreflexia. And then meningitis. There's three kinds of meningitis.
Viral, bacterial, fungal.
Okay, which one's the most common?
Bacterial?
No, viral's the most common and it's the least lethal. Bacterial's the least common and it's most lethal. And then fungal's just out there. It's autoimmune. Pathology is Mr. Pimp, right? It's splash, it's droplet stuff, and you breathe it in. You basically breathe it in. Okay. It gets in the cerebral spinal fluid. It causes that inflammation, and then it obstructs cerebral spinal flow, causes edema, and it affects the tissues in the brain. It can cause ischemia due to increased ICP. So that would be like thrombolytic, right? Because it's compressing. It's not plaques building up and including the lumen. That ICP is causing the vasculature to get closed because it's pressure. Okay. And you still cheated me because you didn't draw a good thing. I'm teasing you. Okay. So it's just related. So the treatment is related to antibacterial and antiviral, antifungal meds, and then vaccinations for those. And then viral is the most common, bacterial is the most severe.
Okay.
And then people that get it are like college and prison and military people. And I have seen this. I've heard of this happening in the Army. I've heard of this at basic training. They get a bunch of nasty, funky soldiers not to clean themselves, and no one's beating them. They're getting beat up, and they're getting like all the time. So they're sweaty and nasty. They don't clean themselves all the time. It can happen there. I've actually heard of it happening there. Okay, what are the signs and symptoms? These are different. That's what we're going over these. These are definitely different. Yeah, that's easy. But yeah.
The neutral.
Yeah, neutral rigidity, stiff neck,
fever.
Okay.
Photophobia. That's like the bright light.
Yep, and that's because their cranial optic nerves are suffered to pressure, and of course they're sensitive to light.
Okay. Vomiting.
Yeah, that's a known one.
LOC.
Yep.
Increased ICP.
This is a weird one.
The red purpuric or blotchy rashes that do not blanch when applying pressure.
Okay. And then just a Kurgan sign and Burdick sign, maybe present. See diagram below. That's this thing right here. Vomiting, headache, drowsiness, joint pain, stiff neck, dislike of light. Okay. And then there's a couple words over here. So opisthonosis is a type of spasm of the whole body that leads to legs and head being bent back, and body bowed backward can occur in some types of meningitis, tetanus, and strychnine poisoning. Okay, and then Kurgic sign and Burkunski sign. I'll read the first one. Kurgic sign is positive when the thigh is bent at the hip and knee at 90-degree angle. The subsequent extension of the knee is painful, leading to resistance. This may indicate subarachnoid hemorrhage and meningitis. Okay, subarachnoid. So yeah, so it's dura, arachnoid, subarachnoid space, pia. So it's going to be in there.
Okay.
Okay, go ahead with the next one.
Burkinski's?
Yeah, Burkinski's, yeah.
Is the appearance of involuntary lifting of the legs when lifting a patient's head while the patient is...
I've never seen this, so this is cool. To be like, Mr. Taylor, but in the head, and the legs are gotta be kind of close. So look at all here. So you look at when you look at the patient's head tilted forward, their legs raise up. Got a little more of this kind of thing, and they move. I'm not sure why that is, but that would be kind of cool. Okay, that's it. That's an hour. I don't know what we're doing.